Members of the media, as you're getting joined, we would like to ask if you don't mind to rename yourself so that we can identify you when taking questions through today's panel. First name, last name, and your media outlet. If you hover over your own video, there's a little option that says rename in the upper corner under that menu. You could also go to the participants list at the bottom of the Zoom program, find yourself under that list, and there's an option for options to manage who you are, and rename yourself is under that. We do welcome members and other participants from our Newswise member institutions and members of the public. We will try to prioritize questions from media outlets. That's why we ask for those in the media to identify yourself with your name and your media outlet so that we can prioritize your questions. Chat those questions to us. We'll ask if you want to ask the question yourself on video and audio, and if not, I can ask the question to the panelists for you. We'll be getting started in just a moment. I'm setting up our YouTube live stream, and we'll be getting started in just another minute. Okay, welcome to this Newswise Live expert panel. We have three experts today to talk about two very important topics that are going on in the news: the COVID-19 pandemic, as well as the Black Lives Matter protests and movement for police reform. I want to give a couple of instructions and introductions, and then we'll get started with questions for each panelist. And we want to invite media who are on the call to give us your questions. You are welcome to use any of the quotes during today's discussion in coverage that you're writing about these topics. And we will also provide a recording and a transcript of today's panel afterward that you're welcome to use for any of that content. We also welcome that you could contact the experts to ask them further questions yourself and arrange your own interview if that's something that you'd like to do. The contact information for the communications offices at their home institution will be part of the materials that we send around with the video and transcript. To chat those questions, just look at the bottom of the Zoom program and click on the little chat bubble. Chat us your questions. We'll ask if you want to ask the question yourself, or if not, I'll ask the question to the panelists for you. We'll go ahead and get started with a couple introductions. So we have first Ann Bailey, Dr. Ann Bailey from Binghamton University. She's here to talk with us about the Black Lives Matter protests and calls for police reform and the history behind those issues. We also have Dr. Eli Rosenberg. He's associate professor in the Department of Epidemiology and Biostatistics at the University at Albany. And we also have Dr. Kevin Smith. He's the chief medical officer at Loyola University Medical Center. Thank you very much to the panelists for joining. One thing that we're going to try this week as well, we did this for the first time last week, is to do a quick poll. And so since we're talking about two big questions here about the pandemic, as well as about Black Lives Matter, we have one question for each topic. I'm going to go ahead and launch that poll, and we'd love it if all of you in the audience would respond. So first, about the pandemic, do you believe that the recent rise in COVID cases is due to increased testing or increased transmission of the disease? Please indicate whether you think it's because of increased testing or increased transmission. And also on the second topic, with a lot of news in recent weeks about the removal of Confederate statues around the country, both by officials as well as those done by protesters in the act of protest. We want to ask this question: is the removal of Confederate statues an important step toward healing racial division, or is it a slippery slope toward erasing history? And we'll go ahead and leave that poll open for a few minutes so that as many of you all can answer as possible. I want to go and start first with Dr. Rosenberg. Dr. Rosenberg's an expert in epidemiology, and we want to talk a little bit about this recent uptick in cases. Dr. Rosenberg, big news just in the last couple of days: the governors of New York, New Jersey, and Connecticut have implemented a 14-day quarantine for visitors from out of state, and specifically states that are currently surging in COVID cases: Texas, Florida, and others. Is it your opinion that those states reopened too soon? And how else can we explain these rising case numbers?
Great question. So I'll start just by saying that it's really hard to make a blanket statement. Like the truth is our national epidemic is really a collection of many epidemics at the state level or smaller. So it's really hard to make a single statement that applies to said all states that aggressively reopened did so too quickly. That being said, at the same time, at the time that many of the states that are currently surging had reopened, and sort of many of which were in the lead up to Memorial Day, the epidemiologic data were not in favor of them reopening to such a liberal and broad degree. Reopening seemed to be more driven by political, economic, and public pressures, and frankly, fatigue. I think part of that is, maybe in the way that we shut down, which is that many states shut down sort of around the same time, a very short time frame, even though the epidemic was not surging in all of those places. So that increases the amount of fatigue that everyone has. I will say though, at the time, many epidemiologists, myself included, thought that we would see a resurgence after such drastic reopenings about a month later, and here it is. So I think, yeah, it speaks for itself.
And do you think the move to issue a quarantine like this was warranted, and would we likely see further interventions needed?
That's really hard to say. And I work very closely with officials here in New York, and I wouldn't comment or criticize, frankly, at this point. I think vigilance. First of all, these are all some of these measures are compulsory, but they're very hard to enforce. So we're really relying on a lot of cooperation, which that's going to limit any such measure. I think these are sort of potential stopgap measures. What we really need is national coordination. That for states to unilaterally act is a very difficult position to be in.
Thank you, Dr. Rosenberg. To Dr. Smith, as leadership at a major hospital in the Chicago area, we wanted to ask you about the issue of ICU capacity. There have been reports of hospitals in several states. I saw headlines today about Houston, for example, all kind of getting close to reaching some level of ICU capacity, somewhere in the high 70s to 80% capacity. What can you tell us to explain what that means when an ICU is full when dealing with a pandemic of this nature, and why it's such a concern?
Sure. Yeah, absolutely. So, surging to a level where ICU capacity is full is really a scary time. And I think to truly understand what that actually means, it's important to understand what goes into an ICU level of care. So it is somewhat the physical plant of it. So it's having a bed, but it also is having that connections for medical gases, to have a room that's large enough to have all of the different equipment that's required to manage these critically ill patients. So not every area can take on the role of being an ICU unit. Additionally, there's ICU staff that has to care for these patients. And those are people that have additional training in critical care and are able to take care of the sickest of the sick. So when you're talking about getting to a level where you have you're at your capacity, that really means that there's not a lot of good options of where you can put these patients and deliver really high levels of care. And in some of these cases for patients who have COVID, they are sick. In some of these, for some of these patients, they were far and away the sickest patients in our hospital. And so, not just anybody could come in and care for them. So you have to have that collection of space and skills to be able to care for that patients. And if you don't have that, then you're really providing, I think, in some ways, substandard care.
Thank you, Dr. Smith. To Dr. Bailey, on the other major topic in the news of late, the Black Lives Matter protests. News just coming out yesterday afternoon that Senate Democrats have blocked the progress on the Republican majority's police reform bill on the grounds that it was toothless, with promises of studies and things like that, but little actual policy change. Do you think they made the right move? And what, in your opinion, should meaningful legislation include?
Well, I do think that in many ways, this is a historic opportunity. This window of opportunity that we have for police reform and other reforms with respect to race and other issues, related issues. This is a time to be bold. And so I think to the extent to which the Democrats are saying very clearly that a chokehold or just advising that we end chokeholds and other more, body cams that we absolutely require body cams, which in many places are required anyway, that doesn't go far enough. I think they really are after the qualified immunity that policemen enjoy. And there are many cases in which qualified immunity is appropriate. But the fact is that there's an abuse of that. And we know that from the many cases in which there's too few, not only indictments, but too few people are actually held into account for killing people because of abuse of excessive force. So I think the Democrats have a really strong case here to make, that we need to do something much more bold.
And that's likely to come in the form of a bill working its way through the House currently. Are you familiar with the proposals in that? And would you explain any of that for us?
Well, some of what I think is necessary, quite frankly, I do think that the Democrats want to go to an extent that probably is going to need a little bit more community support. And I think that's something that they have not, the Republicans are saying that we want to do more studies and so forth. And I'm not really in favor of a lot of studies, but there are situations in which if you go too far without community support, you're just going to get a backlash. And that's what we see as a historian. That's what I've seen over and over and over again, that if you go too far without getting community support, what you're going to get is a backlash. And in fact, what you're going to get is the same policy, but shape-shifted into another version of the same thing. So you will still find police brutality in the streets.
Thank you, Dr. Bailey. We'll come back to Dr. Bailey on a couple more questions about the Black Lives Matter protests and police reform. But I want to spend a little bit more time with Drs. Smith and Rosenberg to talk about the pandemic. Before we get to that, I'll share the poll results. Thank you all for responding. We had 13 out of the audience respond. And I think there's pretty wide agreement that the answer to the first question is increased transmission, with 92% agreeing with that. And on the topic of the Confederate statues, a little bit closer to split, with 62% saying it was necessary for healing division and 38% saying it's a concern about erasing history. So thank you all for your response to that. Very interesting and informative. We have a couple questions from members of the audience, and I want to turn it over to Charlotte Lebov for her question. And I think, Charlotte, this would be best directed toward Dr. Rosenberg.
Right. And first of all, Tom, thank you for doing these wonderful sessions, and hope they'll continue because I think they're great.
Thank you, Charlotte.
Yeah, I live in Florida, and there's a lot of concern about the accuracy of the state's numbers that they give us every day. In particular, sometimes they tend to vary. If you're looking back a day, somehow some of the cases seem to go down from the ones that were announced, and so continue, but that the reduction in numbers is never fully explained. And the state says, well, there's a normal variation in numbers. So I was just wondering if you would address that.
Sure. I mean, so I don't live in Florida, so it's hard to specifically comment, but I'll say in general, with data like this, with surveillance data on case reporting, there's always a little bit of data cleaning and data delays that usually occur in the days leading up to, like looking back a few days from today. And then when we look back a week from now at what was said about today, the numbers should be more stable. So there's always this sort of data cleaning and lagging and fixing process that will occur that can cause some of this. However, the typical direction would generally be in the direction of up, so that there'll be a delay in reporting for today, but in a few days, the reports will come in from laboratories and hospitals and so forth, that would increase the number of cases. To have a systematic decline, over time like this, we're saying that the numbers seem to always go down later, is a little, I don't know, I can't explain that, but in general, we expect always a little bit of wiggle, but once particularly with COVID tests, once you're a week out, it should be stable if you have a system that's working.
Thank you, Dr. Rosenberg. I want to go next to Deb Wood from Nurse Zone, and she has a question for Dr. Smith. Go ahead, Deb.
Hi, during Florida governor's press conference this week, one of the Orlando doctors on the call said, because we know so much more about how to care for COVID patients, fewer are needing ICU level care. They're being treated on med-surg units. Is this true nationally or in other communities, or don't you know? At least tell me what's about Chicago.
Yeah, Deb, that's a really great question. And it's a really great point. I agree with you is that we do know tremendously more about COVID and the pathophysiology of COVID now than we did when New York was hit or even when Chicago was hit. And I think there is some truth in that. I think we do know that if you're proning patients, and that's where you basically put them face down in a hospital bed and you're using oxygen, those patients, it does seem like are recovering a little bit faster or not progressing quite in the same way. Additionally, medications like remdesivir, which has shown benefits, at least in some of the earlier studies, does look like that might help people who are not quite at that intubation level, but sort of before intubation when you're on mechanical ventilation. So I think we are in a better place overall when it comes to COVID. That being said, I don't think that all of these interventions are, the turnaround where we're not going to see any ICU level patients. I mean, even looking at the data, not all patients respond to remdesivir. And I know anecdotally, not all patients respond to proning. Now, what percentage we might be able to see a decrease in ICU utilization because of these techniques? I don't know. I think best guess for anybody, but so I still worry about ICU surging and ICU capacity, but I'm sure there's going to be some patients that aren't going to need it because of these newer interventions that we have.
Thanks for your question, Deb. Dr. Smith, during early phases of the pandemic, especially in the high density urban areas on the coast and then moving toward Detroit and Chicago and other major metropolitan areas, hospitals were reported to be surging their capacity. I wonder if you could help us to understand what that surging term means. And are hospitals in more rural areas and smaller cities able to do that quite at the same level as hospitals in Manhattan, for example?
Yeah, that's a great question. So the surging basically just means that you're seeing a large increase in the number of patients that are coming into the hospital. That can either be through the emergency department as hospital transfers, admissions from clinic, et cetera. And so it's just seeing a large number. This also happened at the time when we were shutting down elective surgeries and procedures, and patients were scared to come into clinic. So we were seeing decreases in those types of patients, but we were seeing increases in the number of patients who either had COVID or were suspected to have COVID, and we were waiting to see if the test would come back positive. And when you surge in that circumstance, you're really filling beds. And also importantly, as I talked about before, is really pulling staff in a coverage model that maybe they're not used to working in. In urban areas, even though we have a higher density of patients, we are a little bit in a better place when it comes to surging. One is we tend to have more beds in general because we expect that we need them for our larger population. And there also can be some coordination between the different hospitals in urban areas as well. I know in Chicago, we had the benefit of having actually in some ways, depending on if you look at it, maybe more beds than we actually need for our population. So there is a way to move patients around in urban areas a little bit more. If you're talking about rural areas, especially critical access hospitals, you are potentially talking about a small number of beds, both on a floor as well as an ICU, as well as maybe a hospital that you're going to transfer to that could be hours away from that hospital. And I think the other piece of a rural hospital is they tend to have less number of staff as well. So if you are talking about somebody who may have caught COVID either in the community or from a healthcare interaction, and they go down or need to be quarantined, that could be a potential significant amount of your staff that then goes down and is not able to take care of those patients. And so, I feel for some of these rural areas that are really seeing a surge because they just don't have the same level of resources that many of the urban areas have.
Thank you, Dr. Smith. Dr. Rosenberg, I'm hoping you can help us to understand a little bit about how the pandemic is kind of moving throughout the country. And while we may see a number of new cases dropping in New York, it's rising in Florida and Texas and other states. In your opinion, is this what we would call that second wave that's been discussed? Or is this really part of the first wave as it spreads throughout the country, and that first wave just hasn't dropped as low nationally as we'd like it to?
Yep, that's a great question. So I think, again, as I sort of alluded to earlier, I think it's really important that to wrap around that there really isn't a national epidemic, that this is playing out locally across the US, and it's hard to give single labels like first wave or second wave to the nation at large. I think to have a second wave means you've successfully fought a first wave. I think that's the really important piece to at least that's my starting definition. And I think in some places like Seattle, like here in New York State, we are to a large extent on the other side of the mountain, as it were. Not fully there, I would say, but we've made it very far on the other side of that mountain. And that was due to massive public health efforts. And so now if we saw a resurgence after being all the way on that other side of the mountain, you might say, yeah, we'll call that a second wave. And it would probably happen some time from now. You'd have to happen some time from now. I think in many of the places that we're talking about in the past few weeks, to pick on Florida, since that's come up already, Texas, Arizona, those places that we're seeing these massive increases did not have that big decline that we've seen in Seattle or New York. They were still on the way up or leveled out, but they weren't. There was not that first conquering of a mountain. And I think this is really better characterized as really a period of acceleration in that first wave from not really having fully controlled the initial outbreak.
Thank you, Dr. Rosenberg. Also on kind of that idea about the acceleration, one of the things that it seems like a lot of people were counting on was for this disease to have a seasonal fluctuation. Lower risk of transmission in the summer months, which comparing to the flu, standard influenza, right? What was wrong with this assumption?
Yeah, I don't know if it's necessarily a wrong assumption still. I think it just may not be a full assumption. So what I mean by that is, a number of studies have shown, looking at weather patterns, that transmission does seem to track with temperature, precipitation, humidity in the ways that you might expect from experience with seasonal influenza. However, it's not a full effect. That the weather may have some impact, but it's not enough to outright halt or greatly diminish transmission during the warmer months, right? We're seeing it's summer and we have large scale transmission in Houston, right? That's counterintuitive. So what we're still seeing transmission despite some modest weather and seasonal effects. And it maybe suggests that what we're seeing across the nation now may yet have been worse if this was the middle of the winter. We're seeing obviously a very troubling pattern, and it could have been worse then. So I would say that the assumption wasn't wrong, but it was insufficient. It's not there wasn't enough to remove the transmission that we're seeing now.
Thank you, Dr. Rosenberg. Back to Dr. Smith for one more question, and then we'll bring Dr. Bailey in to talk a little bit more about Black Lives Matter. On the subject of those ICU beds, and in these kinds of more rural areas, smaller hospitals, less staff, fewer beds to increase their capacity, what happens with those patients, a COVID patient in a waiting room or in an exam room or somewhere that's not as fully functional to protect staff and other patients from contact with them? Are those patients, while they're waiting for a bed or a transfer to another hospital, are they likely to come into contact with others and potentially spread the virus in those conditions?
So I think, theoretically, yes. Prolonged contact, it appears with somebody who has COVID, it definitely can increase your risk of transmission. And so theoretically, being stuck in a waiting room could do that. However, hospitals have tried to do different interventions to try to reduce the risk of transmission. I can't say eliminate, but definitely have tried to reduce it. I mean, we've gone to really universal masking for anybody in a healthcare setting. We try to, also when people come into the hospital, we're screening them right away, performing temperature checks. And that's at least one way that we can say, okay, well, could this person have COVID based on reported history as well as whether they have a fever. And then you do your best to try to separate those people from people who don't screen positive for that. And so those are sort of the techniques that different hospitals have used. I think you mentioned about the rural hospitals, and if you are trying to transfer to another hospital, inherently there's always delays in the transfers, no matter how good of a health system you are, when it comes to coordinating a transfer of a patient from one bed to another bed. It's just natural delays, whether that's waiting for the transport or the ambulance transport or helicopter transport or whatever it is that you're going to use. And so, I can imagine is when other hospitals have a very full ICU and you're waiting for a bed to open up, those delays could get longer and therefore could put that patient at risk of deterioration, even if they do have COVID.
It seems like the more pressure the hospital is under, the more vigilant they have to be about adherence to those practices, right?
Well, absolutely. Absolutely. I mean, and that's why things like PPE were such a big deal, and why there was such worry in places like New York when we were seeing there were shortages in PPE, is that's the way you protect your staff, and that's the way you protect your other patients. And so, making sure either the patients are using PPE when it comes to a mask, or making sure your colleagues have PPE, that's one of the ways to really prevent transmission.
Thank you, Dr. Smith. For a question for Dr. Bailey about the Black Lives Matter protests, I want to go to freelancer in the audience, Yasmin Rasidi. Yasmin, please go ahead and ask your question about the George Floyd case.
Okay, thank you for the opportunity. I would like to ask Prof. Bailey that this is not the first case of police violence, but why the George Floyd incident could trigger the nationwide protests, and how the protests could affect the U.S. election and each candidate's electability, and about the destruction of Confederate statues. What do you think about that? Why are people doing that? Thank you.
Sure, great questions, and they're related. So you're absolutely right that the George Floyd case, of course, is not the first case of excessive force, which leads to the murder of yet another unarmed Black man, right? There are probably a couple of reasons. On one level, frankly, it was so unequivocal. In several other cases, even though effectively it was unequivocal, there were things that people could say, well, he tried to resist, or he moved this way, or he did that. Or, there were always these interesting excuses as to why the police were justified in killing someone who's unarmed, already handcuffed, et cetera, et cetera. I think the fact that it was unequivocal, there are 4 people on top of him, the officer, the main person who is killing him has his hand in his pocket. It's so nonchalant. I mean, the fact that there's a multiracial group of people who are around them saying, what are you doing? Please stop. They're witnesses, if you will. I think that had an enormous impact. The fact that George Floyd called for his mother died 2 years ago. And his dying breath, he's calling for his mother. There's something, others have said this, he narrated his own death. There's something beyond just moving, but profound. I'm a mother of a Black son, he's 17 years old. Who could not be moved by that? So I think that, to me, that's part of what makes this not only a national issue, but a worldwide call to action. That said, I'm concerned that it's not just something that we're concerned about because emotionally we're drawn to it, but that there really is a end result, that these men are not acquitted, which is what's happened in most of the cases like this. And so, I think we have to be really concerned that it's not just kind of a lot of interest in the case right now, but then we don't follow this up. And for the media, we really hope that you follow it all the way to the end, because we have seen this happen over and over and over again, where it starts with protests, it starts with a lot of interest, but it doesn't end with a desired result, and a result that really is based on justice. Is there time, Tom, for me to say something about Confederates?
Oh, absolutely, absolutely. And yeah, Yasmin also was asking kind of about the impact that the pandemic has had on this and what you see it doing to influence the 2020 election.
Okay, so let me just say that coming also at a time when people of African descent are disproportionately being affected by the pandemic for a number of different complex reasons. That also impacts the way in which we looked at this George Floyd murder and having to see it happen in plain daylight and so forth. What's the impact on the election? We don't know. I think I personally hope that the protesters, advocates, media, others, we continue to keep the pressure on for some kind of change in terms of race relations. I hope that the issue of reparations is on the table. The New York Times Magazine is coming out with a big article on this weekend. There are lots of advocates for reparations, longstanding for the last 155 years. And we'd like to see that be an election issue. It's time for that to be an election issue. As far as the Confederate statues are concerned, let me just say that I am not in any way an advocate of people illegally taking down property, on public grounds. I have advocated for these Confederate statues to come down, like many others. And I think that public officials it would be in their interest, as it was in the interest of New Orleans a couple of years back, to actually take these things out themselves. Or Charleston did this just yesterday, I think, with Calhoun. Actually remove these statues so that they don't become symbols of hate and they don't become a place for the protesters to gather and then consider doing illegal things. So I hope that is an election issue, that people do talk about the fact that these symbols of hate need to come down. But more than that, systemic racism needs to be something that we attack full on.
Thank you, Dr. Bailey, and thank you for your questions, Yasmin. I would note about the Confederate statues, we have some very close experience with this here in Charlottesville, where many of our staff are at Newswise. And the city of Charlottesville tried to address this through the democratic process. The citizens voted for a city council that then tried to do this, but unfortunately state law is written as such that those kinds of things can only be done at the state level, and a judge issued an injunction for that. So Dr. Bailey, when the citizens of a city themselves cannot decide about the placement of these monuments, what are we to do?
What are we to do? I know not only that, but then, there's states like Alabama, right, that put in a new state law that said you can't remove any statue, that was built and erected before, 1940. So yes, what are we to do? We are to continue to protest. We are to continue to petition. We are to continue to appeal to state officials. We are to continue to appeal to federal officials. I mean, a lot of this really comes down to, though, how do we convince the hearts and minds of people of America that, we are people of the present and the future. We do not want to live in a past in which we were engaged in the big lie about a hierarchy of races, that we had one race on top and other races in between, and then one race on the bottom. This is not the way we want to live now. So somebody like a Calhoun, who said that slavery was a positive good, why would you want him towering over the beautiful city of Charleston? He doesn't represent who Charleston is today. It's a beautiful city. It's a multiracial city. It's a place that's trying to move away from its past. So I think you just have to keep advocating. I think that advocacy is the key, and keeping the fire burning on this issue and not just taking it up when it's popular or it's trendy or what have you. So that's what I would say to Charlottesville. Keep on doing it.
We have another question from Benita Zahn with WNYT. Benita, I'm unmuting your audio so you can ask your question. Okay, I'm not able to make Benita's audio live. Her question is, the messages. Oh, go ahead, Benita. Thank you.
Technology. Hi, Dr. We've been working on this issue of racism in healthcare. And
Yes.
at this juncture, how do you recommend, what are you seeing ways to help the Black community be cared for better during the COVID outbreak because of the concerns they may have about seeing a physician, because of color differences and barriers, language, understanding barriers? Help us as reporters help the Black community access the care the best they can in this time.
Well, first of all, you have to acknowledge that these are some of these issues, as you really alluded to in your excellent question, are longstanding issues. And the reason that we want to be addressing root causes, which is my commitment, is to root causes, is because when you have an emergency like this, you just can't attack those root causes and actually fix those root causes, in a short period of time. That's just the reality of it. If you have communities which have been denied access to healthcare, along with other communities, not only Black communities, obviously, but poor communities elsewhere across the country, because we don't have a commitment, as you know, to federal healthcare for all, universal healthcare for all. This is going to happen during an emergency. So the first thing I would say is that even though we're trying to address the short-term problem, let's at the same time put the pressure on the long-term problem, because once this emergency is over, eventually there will be another, and there will still be situations exactly the way they were before. At the same time, I know personally, I work a lot of my research work is in Georgia, and there are excellent NGOs that work, grassroots organizations that work to help facilitate and bridge that gap between, regular healthcare institutions and the people. And they have a relationship and can have a relationship with both. And so they're perhaps one of the best, I think, kind of modes through which we can try to deliver that healthcare, both preventative and immediately, to some of the people who really need it. But other than that, I say we have to address those root problems. And once again, it goes back to issues of universal healthcare. It goes back to issues of reparations for people of African descent. There's no question that if you look at the question of reparations, that healthcare would have to be one of the top things on the list. I hope we put it on the top of the list.
Thank you for that question, Benita. And I want to let our other panelists weigh in on this too. Dr. Smith, what have you seen and observed in terms of racial disparities at your hospital and how the COVID pandemic has affected Black and Brown communities?
Yeah, I think it's such a great question because, and Dr. Bailey, you couldn't have said it any better than what you said. I mean, this is the reality, is that we've seen increased illness in many of our communities of color, especially when it comes to looking at the patients who are in the hospital who require an ICU level of care. And a lot of it does get back to those health disparities that are in place. And you're right, during this time, this was not necessarily a time that we could fix those health disparities, but we were seeing the consequences of these health disparities. The way that we tried to address it was, try to give the best level of care in the hospital that was we could possibly do. But then when it came to times of discharge, it was challenging. We took care of a lot of patients who either were underinsured or uninsured, and setting up a safe discharge plan was always a challenge. But what I also found really interesting was, one of our things we talked about is, okay, so do you have anybody in your family who has been exposed to COVID? Because if you don't, you have to self-isolate yourself so that you're not spreading to your family. Well, inevitably, many of these families of color, they'd say, oh yeah, I had it, everybody else in my family had it. And you really were seeing that it was spreading in these communities within families. And that does change the way you think about this illness. I think the other piece is we try to use more telehealth to be able to get to some of our patients of color who may not have trusted coming into the health system, but we were able to connect with them in that manner. I can't say that it was perfect, but we did try to do some more innovative techniques to make sure we weren't losing those patients and having them fall through the cracks.
Thank you, Dr. Smith. Dr. Rosenberg, what does the data show about these racial disparities, and what else would you like to add about this?
Sure. Yeah, I'll just, add on to everything with just a really sweeping sort of population level view that when we look at COVID-19 and outcomes by race, ethnicity, and really in focusing on the Black community versus, let's say, the white non-Hispanic populations, that the disparities are truly multi-layered and go back to community level factors, just like Dr. Bailey had shared. So we have some results coming out next week that really show along a continuum of processes where the disparities might sit. And so, we've already published with New York State Department of Health results from the sero study across New York State showing very large racial disparities in simply being infected to start with, which really points to community level origins. It could be, there's many social and structural factors that simply expose minority groups disproportionately compared to other groups. And that's a real thing. Then, as was just alluded to by Dr. Smith's remarks, that we see differences in the likelihood of needing hospitalization by race, ethnicity, again with African Americans needing that intensive level of care, likely for some of the reasons that have been discussed: comorbidities, other historic access to care issues. I'd say maybe the only silver lining that's emerging in some of the data is that once patients hit the hospital and controlling for some of those comorbidities, that the mortality rates and some of the outcomes, given that you're receiving quality care, don't seem to matter that much, don't seem to differ that much by race, which I think points to good, or at least points to the quality of care that patients are receiving in our hospitals. I think really the roots of this are more upstream, and they have to do with community factors, comorbidities, and the access to care issues that have been described. That obviously in the midst of the pandemic, we can't fix all of it, but it's truly the upstream issues that we're seeing play out in a very rapid pace. And I'll just comment, just for context, a lot of my work historically has been in HIV, where we see the same magnitude of disparities, but they took a far longer time to emerge. HIV moves slower. Here in a respiratory infection, in a pandemic, we're seeing the same disparities occur in weeks. And that is just an experiment that I don't like to see played out.
Thank you, Dr. Rosenberg. Dr. Bailey, I want to ask another question about the Black Lives Matter issues. There have been major developments in 2 cases of the murders of Black men in the United States.
Mm-hmm.
I'm sorry, I'm getting a little off track. One case with a murder, the case of Ahmaud Arbery in Georgia. The grand jury indictment was just passed down yesterday, charging these men. The other case, not an actual murder, but another case just hit the news last night about 3 Wilmington, North Carolina police officers that were fired over recording, catching them talking about some very racist attitudes, and even one of these officers wishing for a race war and threatening to go out and shoot people. These officers have now been fired. Both of these situations developing in the last 24 hours, what does this signal in the case of the indictment for the Arbery murder, which took more than 3 months to happen? And then now this case with the North Carolina police officers, the police chief dismissing those officers very quickly. What does this signal to you, and what does this reveal about police culture, and how is this maybe hopefully changing?
Well, first, I'm going to start with, I like the word silver lining from Dr. Rosenberg. I'm going to start with the silver lining on all these matters. Certainly, because I could start, as a historian, I could start with the early history and keep on all the way up in terms of the history of not just police brutality, but in the Arbery case, really of vigilante justice, right? In this case, white vigilante justice. But what's the silver lining? That at least we are finding a certain amount of public outrage, which I think is very important. And it's not just within the Black community, it is multiracial. It's multi-generational also. This is a huge factor. It's very, very important. We're also seeing that these cases are not being they're not being swept under the rug. They may not, in the Arbery case, I think maybe they wanted action a little bit sooner, but nonetheless, we have some We have charges that are, we have an indictment, we have charges. I think one of the charges, which I found interesting, was malice murder charge, which, I mean, I could take a whole day just to break that down. But the fact is that we are seeing some progress and at least movement towards justice. That said, I think that we have to understand that this history that we need to reckon with it. Those three men that essentially entrapped Arbery on the street, they were playing out a long-standing tradition of vigilante justice. They can decide for themselves, they can be judge and jury as to the life and the death of any Black person. And in this case, somebody who's just jogging down the street. And I think we have to deal with, once again, we have to deal with why is it we're in a society which gives them permission, if you will, to think about a person of African descent in this way. How do we create a society that does not give permission, that creates boundaries, that even if you have that intent or you have that random thought, you cannot play it out because it's clear that Black lives matter. Black lives matter in healthcare, Black lives matter in education, Black lives matter in the economy, right? If you are you create a mindset and a social climate and a political climate in which this kind of behavior is just unacceptable, it will stop happening. And I really do believe that.
Thank you, Dr. Bailey. It's particularly disturbing as it's so akin to lynching, and there have been, I think, 6 or more cases of unsolved hangings that appear
Absolutely.
to be lynchings in recent weeks.
Absolutely.
Thank you, Dr. Bailey. To Dr. Smith on the pandemic again, lots of reports about the ICU limits and especially some reports of children's hospitals now needing to open things up to adult COVID patients. What are some of the logistics and breakdowns of healthcare system transferring patients around to facilities, and who coordinates these efforts, and how can we be assured that this is being done properly and effectively?
Yeah, it's it's an interesting time when you're seeing children's hospitals being used to take care of adult patients, and we always say in medicine is that kids are not just little adults, and it's vice versa as well. So the way that a pediatric hospital is set up may not necessarily be set up in a way that's always conducive to adult level of care. So in whether that's dependent on, again, the physical plant, whether it's the staff that are there and how they're trained and how they're taking care of adult patients. But during desperate times, desperate measures are taken.
Mm-hmm.
The way that transfers generally work is, there is a hospital realizes that they need help, and so they're requesting another hospital to help them. And then there's an aspect of sort of accepting that patient based on bed availability. And then there's transportation that occurs between the different hospitals. And there might even be times where patients are too unstable to actually be transferred. We do see that at times. And so, as I mentioned earlier, there's just always going to be inherent delays in transfers. And anytime you're talking about delays, there's always the chance that patient's status changes. And therefore, you may even lose your window to be able to get them to another hospital that can care for that patient. And so, the question of how do we manage this and how do we coordinate it, it's a really interesting one, because generally it's up to the institutions to coordinate things. So it's really the role of one institution asking for help, another institution saying, yes, I'll take that patient, and then setting up that transportation. And so we're just not used to having sort of one group or one body that manages that. I can say in Illinois is that we have, we separate our different areas, different hospitals into regions, and the region has some ability to coordinate things based on the hospitals in their area. But I can say just from standpoint of Chicago, we're very close to Rush, University of Illinois, Chicago, not too far away from Northwestern University of Chicago. but all of us are in different regions. So we're in a very different region than the rest of Chicago. And so there's not a lot of a coordination between different regions. So, we don't really have a great coordinated process. I think we also, during this time, we understood that we were all in this together. And so I think, when different hospitals reached out to us for help, we were willing to help them as best as we were able to, because we knew that we were all responsible for caring for our communities. And so, there's not a great regulatory way to do this. But I think, fortunately, in medicine, most of us are in this for altruistic reasons, and we realize we have to help each other because there's a good chance that other place is going to help us at some point down the road as well. And that's how most of this has happened.
Dr. Rosenberg, why is it so important for a coherent national strategy versus leaving so many of these decisions and logistics up to the states?
Yeah, no, that's critical. I can't overstate the importance of national coordination in times like this. Although the federal government is not officially charged with running the public health response to COVID-19, public health is traditionally a state role. It has a large potential to play in providing critical advice, scientific data, and logistical support, and really conveying a coherent, coordinated national plan. So I think coordination is really the piece. The federal government doesn't have to command, but it can coordinate. And I think the Department of Health and Human Services and some of its agencies like NIH and CDC have done this well in prior outbreaks and national health crises, and they can do it again. I think the challenge here is that where we're at now with the current level of federal leadership, the US will continue to be a checkerboard of state responses, and that's not good. We're gonna have different epidemics. And as people travel state to state, and one state's victory in getting over that mountain could be compromised by another state's lack of progress, and we'll keep going in cycles. So that's really on the epidemic side a tragedy. I think on the other sides of this, federal coordination and stockpiling and distribution and negotiating, which became very important. Negotiating prices for vital resources like personal protective equipment, PPE, and testing supplies can really hamper and frankly make impossible local efforts, right? So if you have different states outbidding each other on ventilator costs, no state can afford something. It just doesn't make sense. So the federal government, that's why we have a federal government, is to step in and sort of help resolve those issues. It's really important and it's just critical.
Thank you, Dr. Rosenberg. We have just enough time for one final comment from Dr. Bailey on the Black Lives Matter issues. And I want to give you a chance to tell us a little bit more about what we should understand about Juneteenth. Last Friday was Juneteenth, celebration of the word reaching slaves in Galveston, Texas, enslaved people in Galveston, Texas, about the Emancipation Proclamation 2 full years after it had been announced. Why is Juneteenth so important, and what should we understand about it?
Well, it's a great question to end with, because it's 2 years after the Emancipation Proclamation in 1863, and effectively Texans then were denied their freedom. It was a delay in them receiving their freedom. And it says so much. It's such a fitting metaphor, isn't it, to what's happening now, today, and why people are protesting today, and why a multiracial group of young and old alike are outside saying, it's been too long. It's been 400 years, more or less, since some of the first people of African descent made this became their home effectively because of the slave trade. They were forced to migrate here. And yet we're still seeing justice denied. We're still seeing freedom denied, not even the freedom to jog or the freedom to lie in your own home, in your own bed, and not have a no-knock warrant be the reason that you are killed in your bed. And Breonna Taylor's name, I hope we won't forget, because justice has not come there yet. So Juneteenth and the fact that freedom was not denied, but delayed, really is a fitting metaphor for where we are today. And I want to say that when we get to the point when Black Lives Matter is not just a phrase or a slogan, or even just a movement, when we get to the place where we really have equality in healthcare, in education, in the economy, in all these important things. That's going to make the work of people, the amazing work, just listening to my colleagues here, like Dr. Smith and Dr. Rosenberg, it's going to make their jobs that much easier, because we're going to see those disparities start to close, and we're going to see that we can look at new challenges as a nation, not just the same old story for 400 years of racial disparities, which break out every now and again into a big storm, but are never really solved. I'm looking forward to that. I hope that the celebration of Juneteenth in at least a number of the states, including my state, New York, becomes a federal issue, and that becomes a federal holiday. Many people have fought for that for years. I hope many people on the grassroots level have fought for that for years. I'd like to see that happen, and may it issue in a new day, just a new day, new challenges, new innovations, as opposed to the old story of we still haven't found a way to work together, to live together, and to dream together.
Thank you very much, Dr. Bailey, for closing on that note of optimism. We are going to wrap this up because we do have another panel scheduled for 3 o'clock. If you're interested, we are going to be talking to 3 cancer researchers who are turning their efforts to fight the COVID pandemic and talking about trials and new therapies that they're investigating. So if you're interested in that, please do stick around and join us for the 3 o'clock panel. We're going to close this one down and just take a short break while we get set up for that. And before we go, I do want to say thank you to Dr. Smith at Loyola University, Dr. Rosenberg at the University at Albany, and Dr. Bailey at Binghamton University. For all of the media, we're going to make sure to get you that recording and transcript as soon as that's available. If you were on the list and registered for this event, you're going to get that. If you didn't register and you just click the link to join today's meeting without registering and you want that info, send us an email at info@newswise.com and we'll make sure to get you on that list. Stick around for the next panel. And if you're going to leave us, I'll say stay safe, stay healthy, and good luck.
Thank you.
Thank you.
Bye-bye now.
Thank you so much, panelists. Feel free to stick around if you have time and want to hear from the cancer doctors that we're going to be interviewing shortly. We've got a few of them joining now, and media who registered for the 3 o'clock event should be getting logged in. Thank you so much. If you are in the media and you're going to be participating in our next panel, please change your name so that we can identify you when we take questions from the media. There's a little 3-dot menu in the upper corner. If you hover over that and click rename, you can add your first name, last name, and your media outlet. For example, Wes Montooth, Action 2 News, and that way we'll be able to identify you when you chat your questions to us. So to submit your questions, simply click on the little chat bubble at the bottom of the Zoom program, chat your question to us, and I'll ask if you want to ask the question yourself. If you are in the meeting right now, you can just stay right here and wait for the next panel to start in just the next couple minutes. We'll ask if you want to ask the question yourself, and if not, for whatever reason, I'll go ahead and ask the question on your behalf. Dr. Jensen, I see that you've joined. I'm going to go ahead and make you a co-host so that you'll be able to control your audio and mute and unmute yourself. I see Dr. Morrison there as well. Hi, thank you so much for joining. I'm gonna give you co-host privileges as well so that you can control your audio. If you could just do a quick audio check for me, that would be great.
That sound okay?
It does, it does.
Thank you, sir.
And Dr. Jensen, could you give me a quick audio check?
Sure, this is Roy Jensen.
Loud and clear, sir. Thank you very much.
All right.
And we should have one more of our panelists, Dr. Puzanov, joining shortly. And I'll make those announcements with instructions for the media attendees a few more times as we get started. Dr. Morrison, if you could rename yourself with your institute's name on the end of your name, that would be great and help our attendees identify you. Did you hear my instructions for how to do that? If you hover over your own video, there's that little 3-dot menu in the upper corner, and under that is an option to rename. And if you could just put Roswell Park Cancer Center or Comprehensive Cancer Center, if you want to put the full thing.
I'm working on it.
Okay.
I didn't do it right though. But... That better?
That looks great. Thank you. For media who are getting logged in for this expert panel, I'd ask if you don't mind to please rename yourself so that we can identify you when we're taking questions for the panel. To do that, hover over your own video and there's a little 3-button menu in the corner, and under that is an option to rename. You could also click on the participants list and find your own name under that list, and then to the right there'll be an option to edit your name there. If you put your first name, last name, and your media outlet, that will help us to identify you when taking questions through today's panel. So we're going to start with a couple questions that we have prepared for the panelists ahead of time so that you get an idea of some of the topics that they're going to talk about. And then we'd love to hear questions from you. So take a look at the chat option at the bottom of the Zoom program, chat your questions. If you want to get on audio and video to ask the question yourself, we'll invite you to do that. If you don't want to do that, I'll ask the question on your behalf. Just let me know in the chat. And also, if you have a preference for which panelist to ask your question, it'd be great to know that as well. We'll be getting started in just another minute or two. We are expecting one of our other panelists to join any moment now. And we'll go through a couple of these instructions one more time before we get started. And one thing I do want to make sure to mention to our media who are on the call, you are encouraged to use any of the comments and discussion in today's panel in any of your work. And to that end, we will be providing a video recording and a transcript of the panel after that's available, after we're concluded. So if you registered for the event, you're automatically on the list to get that info once we have it available. If you didn't register and you're just clicking a link from an invite that we've sent out to join, and you would like to get that info, please send us an email to info@newswise.com, and we'll make sure that our team adds you to that list to get that information when it's available. Okay, we'll be getting started in just another minute. We've got our third panelist here joining, and I'll make a couple of announcements for instructions again once we get started. Dr. Puzanov, I'm going to make you co-host so that you can control your audio. And just going to give him a moment to connect his audio. So for media who are on the call, just a couple quick notes one more time before we get started. We'd love to hear your questions. So we're going to start with a question for each panelist so that you can get a sense of what they can talk about. And then we'd love to hear questions from you. So take a look at the chat function in the bottom of the Zoom program and go ahead and chat your questions to us. We'll invite you to ask the question yourself, or if you don't want to do that, I'd be happy to ask the question on your behalf. You are welcome to use any of the quotes in today's panel for anything that you're working on. And to that end, we will provide a video and a transcript of today's panel so that you can have access to all of that information. If you registered for today's event, you will automatically be on the list to get that information. If you didn't register and you just clicked a link to join from an invite that we've sent out and you want to get that information, send us an email to info@newswise.com and you will be added to the list. So we'll go ahead and get started. Welcome to this Newswise Live expert panel. We have with us three panelists to talk about cancer doctors and cancer researchers pitching in on the fight against COVID. These professors and researchers are from several different cancer centers. I'll introduce them in just a moment. And they're going to talk about how ways that cancer research has enabled them to start looking into what possible treatments there are for COVID, as well as other topics related to that. And I want to go ahead and make a couple introductions. So we have Dr. Igor Puzanov. He's professor of medicine, and he's also director of early phase clinical trials and co-leader of the developmental therapeutics program and chief of melanoma at the Roswell Park Comprehensive Cancer Center. Quite a lot of duties you have there, Dr. Puzanov. We also have Dr. Carl Morrison. He's in anatomic pathology, and he's also senior vice president of scientific development and integrative medicine at Roswell Park Comprehensive Cancer Center. And last but not least, we have Dr. Roy Jensen, director at the University of Kansas Cancer Center and director of the Kansas Masonic Research Institute. Thank you so much for joining us, panelists. And I want to start with Dr. Puzanov, if you're ready for us, and ask you to tell us about why cancer researchers have joined this fight against COVID and what unique insights from cancer research do you feel can be applied to the fight against COVID? Your audio's not live there. If you want to make sure that your phone audio is connected, if you could just give me a quick test. Try one more time. I'm sorry, Dr. Puzanov, we're not hearing you.
Okay.
Oh, I am hearing you now. Great, great. Thank you so much. Sorry for that mix-up, everybody. Dr. Puzanov, tell us why cancer researchers joining the COVID fight is so important.
Yeah. So the cancer and infection have a lot in common. You know, it's the processes involve the immune system and the inefficacy of the immune system to actually clear either the cells which went into the cancer pathway, or the viruses or bacteria which are kind of breaking through. So the background in cancer immunology, actually prepares the researchers in the oncology world well to kind of weigh in on the COVID or other emerging infectious diseases of that kind. So, from that background, it was only natural that our cancer center got involved into the COVID situation pretty early, actually in late February, early March, because the other part of being oncologist, means that we are connected, worldwide. So we have seen actually that the situation was getting dire in Asia, in South Korea, in Europe, Italy, and so before it actually came to U.S., we have been aware that it's coming and, about the nature of the threat. So that's why we got involved.
Thank you. And tell us a little bit more about this immunotherapy research and how findings from cancer studies about using different molecules to stimulate the immune system to potentially fight cancer, how that translates to fighting a viral infection like COVID.
Yeah, so there are some similarities and some dissimilarities, but in general, the immune system should detect any danger and clear it, before it becomes, fatal to the organism. And when you think about cancer, cancer usually means that somehow that first line of innate immune defense, meaning like the natural immunity we all have against, big threats which we inherited from our ancestors, got broken through. And that same innate immunity actually protects us from major pathogens like tuberculosis or gram-negative bacteria, or actually pieces of DNA or RNA which don't belong to our organism. That's through the system called toll-like receptor system, which actually led to a Nobel Prize for the researcher at the UT Southwestern. And so this is one part, and the other part is the adaptive cell immunity, which is the second in line and kind of picking up pieces from the first line of defense and developing specific antibodies or T cells we are all familiar with. And when I say T cells, that's the same cells which are being influenced by checkpoint inhibitors like Keytruda, Opdivo, and others we all know are used to fight cancer. So there is that connection between immune system, cancer, and virus. And to be more specific, with this virus, you have two problems. One problem is actually inability of some people to kill the virus immediately upon arrival, i.e. kill it, right away using probably the innate immune system. If it's very strong, you will never get infected, at all, not even asymptomatic, you simply don't get infected. And then the second line is that some people actually kind of harbor the virus doesn't go away, they are unable to get rid of it, and as it's kind of in them, they enter this vicious cycle of being more activated, and finally their immune system enters what we now call the cytokine release syndrome, cytokine storm. And that's actually overactive immune system, which is ineffective. It's not killing the virus, and it's actually damaging the host, damaging the patient. So you have several options, to enter the cycle of the virus and intervene using actually some of the immune system paradigms we have learned along the way. So that's kind of in general a high overview of that connection.
Thank you for helping us understand that, Dr. Puzanov. I'd like to ask Dr. Morrison if you can tell me your thoughts about why you feel it's important that cancer researchers have joined into this fight and what particular skills and knowledge they have to offer.
Yeah, what I'd kind of like to emphasize a bit of what Dr. Puzanov was saying about the immune system. I think to layer more additional details on top of that, one thing we've always been very accustomed to in cancer is that there's a lot of heterogeneity in response. So 2 or 3 people can get the same cancer, and one will have a very dismal outcome, and one will have a great outcome, and one will have a moderate outcome. And I think we're seeing the exact same thing with the coronavirus and the COVID-19 epidemic or pandemic. And out of that, what has sprung a whole new area of medicine that's referred to as precision medicine. And while precision medicine, or explaining the heterogeneity of response to either some type of an assault on the body, while it has been discussed and used in many other areas of medicine, it is by far and away, cancer and cancer care has been the leading poster child for precision medicine. And at the front of precision medicine is what they could refer to as molecular techniques, right? How do we interrogate the immune system? And one of the most common ways that we're doing that today is using a really sophisticated tool set called next generation sequencing to look at these various immune cells that are actually the policemen of the immune system. And from that, I think that we've been doing that for quite some time in cancer. And if we're taking that same type of an application to viral infection, it could make a difference.
Thank you, Dr. Morrison. To Dr. Jensen, I'd love to hear your thoughts about what it means for cancer researchers to pitch in on this fight and how your center is responding to the pandemic itself?
Sure. Can you hear me okay, Tom?
We can.
Very good. So first of all, thank you for having me on the forum. And when the pandemic hit, particularly Washington State and New York City, we could clearly see that it was heading our way. And so back in February, we started planning for this event and discussing, how we could depopulate our clinics, how we could delay screening and other approaches to our cancer patients, and to specifically look at who could work from home. And so when the decision was made on March 16th at our institution to kind of shelter at home and shut things down as much as we could, we were ready. And that was a tremendous benefit to us to have that, week to 10 days to get ready. And that was clearly not available to folks in either Washington State or on the East Coast. And so we were very thankful for that. Like I said, one of the first things we did was to figure out who did not have to be in our cancer clinic, over the course of the next 2 months, and who could we delay, follow up, and who could we switch to telemedicine, who could we switch to oral medications, and all of those things were a critical part of our response, trying to prioritize patient safety, first, and then to see how successful those strategies were.
Dr. Morrison mentioned precision medicine as part of the work that they're doing at Roswell Park Comprehensive Cancer Center. I want to ask what other kind of precision medicine is happening there at the Kansas Cancer Center?
So there's a number of things that are ongoing. We just opened a new clinical trial in partnership with a St. Louis biotech company on a Mk2 inhibitor, and that's basically an inhibitor or a component of the MAP kinase signaling pathway, which controls the production of a wide variety of inflammatory cytokines. And so the idea is that we could selectively downregulate the expression of all of those proteins that are stirring up the inflammatory response to the virus, and keep people from progressing to adult respiratory distress syndrome when they had a severe infection. And we're just now in the process of opening that trial up.
Thank you. Dr. Morrison, can you tell us a little bit more about your precision medicine work, and especially the biomarkers that you're looking for to try to identify which patients may suffer more severe cases of COVID versus which may not, and how we can perhaps determine that earlier on when they're diagnosed?
Yeah, let me go back to, I'll try to put this in maybe simplistic terms, right? But we were talking about, the immune system protecting your body, right? And there are basically two types of policemen in the immune system. We refer to those as B cells and T cells. And each of those B and T cells that are in your body, or each of those policemen that are in your body, are no different than all the policemen today that are in a major city, that each person is a little bit different, okay? A little bit different, right? And if we were to say, well, how could you tell when a really big event was occurring in that city? And the way you could tell is that there'd be lots of policemen there, and lots of those policemen would be different. They're different from each other, okay? So we're basically taking that technology called next generation sequencing, and we're looking to say, how many policemen are showing up at the coronavirus attack? And are all these policemen different? Because if we know if there's more different policemen and firemen and everything there, we refer to that technology as convergence, right? And we're actually using that sequencing of the policeman's DNA, each policeman's DNA, to say, are there a lot of them there, and are they exhibiting what we call convergence? Therefore, we know it's a big event and it'll get me treated. And if you look at perhaps one of those people who are having a poor outcome with the coronavirus, it's very likely, right, that's what's happening. They have policemen showing up, but just not that many different policemen. So it's not a big event for them. And if we go through this, I think we'll find that, if there's not just two types of infections with coronavirus, there's probably multiple types, right? That, as we know, some people are asymptomatic, right? Particularly younger people, right? And that there are some people that get typical flu-like symptoms. And then if you remember, there was one family in New Jersey, 4 members that ranged in age from, I think, early 40s to 80 years old that all died in 1 week, right? So it's telling you that there's something in our, that's common among our inheritance and our immune system that's preventing or fighting the coronavirus.
Thank you for that explanation. It helps a lot to understand what it is that you're looking for. Dr. Puzanov, with regard to convalescent plasma, there's been a lot of information in the media about this. I've even seen a kind of public service campaign featuring movie stars and celebrities and athletes saying, if you've survived COVID, call this number to learn how you can donate your plasma to research. What's being done at your center on convalescent plasma?
So, we have Dr. George Chen in charge. He is a bone marrow transplanter, so it's his specialty to collect plasma and cells. And, ever since beginning, we joined with Mayo Clinic and started collecting convalescent plasma. But like Dr. Morrison alluded to, we have been fortunate not to have that many patients. I think overall we have seen only 18 patients, with COVID overall, between March and now, or maybe a little bit more, but not that many. So we collected what we could, and because we didn't have any cases, we actually are sharing that plasma with regional centers because they need it more than we do. So yes, convalescent plasma may be good, and as you now know, there are studies, one by Eli Lilly and one by Regeneron, where they actually use those antibodies, against the virus, and they isolated those antibodies from the plasma, and they multiply them, and now they are using them in clinical trials, and I think it was, there are some groups believing that this could be one of the most important pathways to attack the virus, with simply multiply the best antibodies you can isolate from these random plasma samples and optimize them, and then, make them in large quantities and give them to patients when they are early in development of COVID syndrome, when they are just infected, because it will prevent, ideally, the entry of the virus through that spike protein, that little spikes on the surface into the lung of the infected individual or other organs. So that could be actually very, very good. And although not vaccine, this could actually do. So I like that line of research, and I think it's very promising. And yes, if people did go through the disease, it is kind of wise to call the local COVID, hotline and say, I would like to donate. Do you need me? Because you may actually have some special gift for somebody who may actually need it. And there is a lot of cases outside. We are New York, so we were early, but now the cases are rising elsewhere. So I think it's still important to be on our toes and contribute to other people's care.
Thank you, Dr. Puzanov. Dr. Jensen, there have been a lot of recent reports that new cancer diagnoses have been way down due to patients potentially being reluctant to come to the doctor, go to the hospital for screenings. There have been reports of rises in death from stroke and heart attacks as well, while patients stay at home and avoid going to the hospital. What concerns are there that patients may present later with more advanced stage disease? And what do those numbers kind of signify to you? And what can be done to reassure them that they can safely come and see their doctor in spite of the pandemic?
Well, Tom, you highlight a very important issue. And in fact, Ned Sharpless, the director of the NCI, just had an editorial this week that the data that he looked at suggested that as many as 10,000 Americans may wind up dying prematurely of cancer over the course of the next decade as a result of the interruption of screening and prevention services during this pandemic. And so, you know, you really highlight a hugely important issue, and we've been working awfully hard to make sure that our patients understand that this is a safe place to come. Knock on wood, we have not seen any transmission of the virus to any of our healthcare workers. We have started a program of voluntary testing for COVID among our faculty and staff to assure our patients that our workforce is safe and this is a safe environment. And, you know, we've completely redone the way that we practice medicine to make sure that we're engaging in social distancing and PPE. And what you know, one of the luxuries that we had at our institution is that there was never a PPE crisis here. We were always able to stay ahead, and so we never had either faculty or staff without benefit of appropriate PPE, and I think that's been a key thing to limit transmission of the virus.
Dr. Morrison, you talked about precision medicine and research into determining patients having less severe or more severe cases of the disease. Are those kinds of techniques also applicable to determine what treatments might be most effective as it is in cancer?
I'd say it's probably a more complicated question, but certainly you can't ignore the fact that treatment is associated with response. And, you know, we've definitely seen that, you know, two people getting the same treatment with the same disease have a different result. I definitely think that as we move through this process, we will be able to compare people who got different treatments but had the same immune background and perhaps sort out what is the better treatment based upon what your immune cells look like in your body. And I think that's a realistic hope that we will get to, but I think we're a considerable amount of time away from that. You know, we will probably fully be within a vaccine before we reach that point with precision medicine with COVID virus. I would hope so anyway.
Dr. Puzanov, tell us about some of the other drug trials that are underway at your center and what those drugs, what class of drugs they are and what they might potentially do if found to be effective. Your audio should be live and there we go.
So, you know, like right now we have randomized trials for two drugs which actually, you know, met their primary endpoint. You know, dexamethasone, which is actually an old drug and very cheap, about $5 or less, you know, a day, 6 milligrams daily for 10 to 14 days, actually improved survival of patients with both moderate or, you know, severe COVID, you know, meaning like patients who are on at least some oxygen requirement. You know, the death rate went from 25% to 20%, so relative improvement 25%. And then for the intubated patients, the really severe, you know, the critical COVID patients, it went from like 44 to 38%. So, you know, that was actually like 1/3, you know, decrease, you know, relatively speaking. So that actually is the only drug with statistically significant improved survival. The remdesivir, you know, people, you know, talk about a lot, actually didn't reach statistical significance for overall survival, probably because the study was stopped early because of different considerations and the need to have some drug, you know, available. So we have two drugs, you know, the remdesivir seems to be working better early, you know, in the lighter cases. It makes sense because it's an antiviral, so you want to kill the virus. The dexamethasone is actually kind of calming down the cytokine storm. So it's working better actually in the severe or the critical cases, which again makes sense because you are not actually killing the virus at this point. You are just calming down the patient's overactive immune system. And those are the two drugs we have confirmed. The other drugs are under investigation. Dr. Jensen mentioned the Mk2 inhibitors. The other interesting drugs would be Mk2 inhibitors. Again, master switch of different cytokine production. Bruton kinase inhibitors, whether it's acalabrutinib trial with AstraZeneca and NIH. We almost did that trial, but again, ran out of patients before we could start. And then Ohio State is actually doing ibrutinib, the kind of the original Bruton kinase inhibitor. And multiple people are doing multiple things, which of course, brings out the question whether any of these studies can be finished successfully and show us the data. Last but not least, the IL-6 inhibitor tocilizumab as well as sarilumab are under investigation, again, calming the cytokine storm. But it's a lesson to be learned. We were kind of surprised. We did what we could. We are still doing what we can, to develop, effective drugs for the disease and hopefully vaccine. There are some ideas, of course, for specific vaccines. We all know about the Operation Warp Speed. It's a really like a lot of speed there. 5 companies were selected for that, and then there are other people trying to develop vaccines. The one caveat I would say about vaccines, with HIV virus, which is different, I give you that. People talk about vaccines since 1985 and it's 2020. We still don't have vaccine. There is an interesting idea actually to repurpose some old vaccines like a TB vaccine or oral polio vaccine, with the idea that if you are exposed to the live attenuated weakened virus, you may actually boost your innate immune system. And there are some theories that in Eastern Europe specifically, where people were vaccinated with either TB vaccine or live polio in the old days, that the death rate seemingly is lower in those countries from the COVID. So people are bouncing around ideas, and I have no doubt that we learn a lot from this. And I really commend Dr. Jensen and his leadership, as well as our leadership, for actually not underestimating the crisis and being ready with a lot of PPEs and ventilators and support for the staff, because supportive care actually matters a lot in this disease as well. And that's what I would say. So remember the dexamethasone and remdesivir, 2 drugs approved by FDA with proven data right now, and more coming.
Great, thank you, Dr. Puzanov. From what I understand about the reports on the dexamethasone increasing survival being as a steroid, I believe, helps to support the respiratory system in spite of the infection, so that the patient doesn't have their oxygen level drop significantly. Is that right?
So basically, dexamethasone is anti-inflammatory drug. So it's actually affecting the same pathways like tocilizumab or sarilumab or the Mk2 inhibitor or possibly Mk2, because it like dampens the immune system, dampens the inflammation, dampens the production of the cytokines, and it does it at like fraction of the cost of anything else, because like the whole thing costs like $5 instead of 5,000. Pretty amazing actually. And you can give it by mouth. So if you are able to take oral medications, like if you are just, let's say, on 5 liters of oxygen, just sick, but not like sick, like deathly sick, you take your dexamethasone, and after a couple of days, if you feel better, you can go home and finish the pills at home. This is really good. This is really important trial. And the other one I would point to you, like Dr. Morrison mentioned the genetics, and kind of differences between individuals. So there is a New England Journal paper actually from the New York, Memorial Group and others, the GWAS group, the genome people, and they found some connection between a blood type, blood type A being 45% more likely to suffer severe COVID, blood type 0 actually 35% less. So, like if you have 0 or A, the A's have double the risk of O. So there is some connection there, and they found some other possible connection. And, so there is some interesting things to tease out, about the genetics and inheritance. because it is really strange that some families, 3-4 individuals, die from the disease. And then you have populations where the COVID seemingly is not as deadly, as some other, situations. So a lot of it's going on, and we at Roswell are part of the Global Virus Network, Dr. Gallo's, Global Virus Network outfit. So I was on a call this morning at 6 o'clock. We have every week calls, around the world with Singapore, China, you name it, South Korea, Italy. And we discuss, the efforts, which are going on around the globe. It's very impressive, actually, on all the different fronts, on all the different points in that continuum of care for patients with COVID. There are a lot of efforts going on. So, it's going to be really, actually, at the end, positive for science and for preparedness for these threats. We haven't had that threat for 100 years. I think if it comes next time, there will be a totally different ballgame, in place.
Dr. Jensen, you mentioned success at your center in avoiding transmission from patients to healthcare workers and staff. What measures have been most effective in that? And what does that tell you, or what should that tell the public about the importance of things like masks and social distancing?
Sure. I would say it's hard to say which intervention has been the most effective, because we implemented a broad number of things simultaneously. So it's not like we did a controlled study trying to figure it out. We were essentially adopting an all hands on deck approach to try everything that we possibly could. I'm quite certain that tailoring the PPE to the situation, for instance, there's kind of a higher level of PPE called a PAPR, which is appropriate for when you think you may aerosolize the virus, say like doing a bronchoscopy exam. And as you might expect, that has a tendency to generate quite a few droplets and aerosols, whatnot. And so folks doing those, it's critically important that they have on the highest level PPE that we can get them. If you're just in a more normal clinical setting where you don't expect that you'll generate those kinds of things, I think a normal surgical mask or an N95 mask in other situations, is certainly appropriate. So I think being able to tailor that, you can't wear a PAPR to every single interaction, with somebody, because obviously that is much more expensive, and there's limitations on the availability. And so I think trying to make sure that you're appropriately gowned up for the situation that you expect.
Can you elaborate on a PAPR?
So it essentially kind of creates a controlled airspace. It's sort of like a little bit like a helmet that prevents, that controls your exposure to any aerosols that would be in the room when you go in to do the procedure.
Gotcha. So it's something that the physician would wear.
It's kind of like a biosuit, essentially, for the head. Yeah.
Gotcha. There's been a lot of discussion about racial disparities revealed by the impact of COVID. And there's a lot of similarities with those kinds of rates with other diseases as well. And I wonder what your thoughts are about that, and what you're seeing in your work, in your research, and how big of an impact those racial disparities are with cancer and with other diseases as well, and what you think needs to be done about it.
Well, pretty shortly after the pandemic hit, it became clear that this is a huge issue, and you don't have to look any farther than places like Detroit or New Orleans, New York, to see that African American populations, Hispanic populations, um, folks in lower socioeconomic status and high levels of chronic disease were significantly greater impacted by this virus than other groups. And just an example from our place, the death rate for African Americans that test positive for the virus in our area is 5 times greater in African Americans. 5 times greater. That's a stunning, just make your jaw go slack statistic. And so, you know, it's very clear that this virus has exacerbated those types of disparities issues almost more so than in practically any other situation that we can point to.
Thank you, Dr. Jensen. Dr. Morrison, I'd love to ask you to explain a little bit more something that you mentioned earlier using next generation sequencing. This technology that I understand is part of these kinds of precision medicine studies. What exactly does that enable, and how is it different than what maybe was available in a previous generation, and where that's helping you go in how you do this research?
Yeah, I think, you know, that question is also relevant to the disparity issue and the fact that genetically, only 1% of our DNA is different between one individual and another one, but there are certain racial differences in our DNA, and it could account for some of the severity of infection that we see in African Americans, and perhaps it's not just related to, the socioeconomic issues. But if we look at, how do we investigate that in the technology called next generation sequencing, and what that enables us to do is sequence, your DNA is made up of an alphabet code, and it's a very simple code. It only has 4 letters, right? But it's arranged in all these various combinations across short regions and long regions. And prior to really about 2003 or 4, we basically could only look at very small regions of your DNA. In other words, maybe 150 or 200 base pairs at a time. And if you stop to think about this alphabet, if you took the DNA in any one cell in your body and said, well, let's make it the alphabet as big as it could, as something that's in a newspaper, if you stretch that out, it would almost reach the moon. Okay, so you understand that if we were just looking at this, if we were trying to read that newspaper one line at a time, as we were doing, 15 years ago, we would never get there. So then, a technique sprung up, and that technique was really called second generation sequencing. And over the years, that terminology was transferred to next generation sequencing that enabled us to basically read all those letters at the same time. And it's just been transformative in cancer care. It has just really made it's now become in many disease types like lung cancer, the first tool you reach for to say, how should we treat this patient? And hopefully, we will get that way with the COVID virus and susceptibility, and it'll have impact and disparity. We'll be able to look and say, is all this difference in racial inequality just due to socioeconomic status, or is there some genetic reason or some component of it that we need to tease out?
And when you're able to identify what that genetic code tells us, does that influence, for example, how the patient's T cell and B cell receptors function that you were talking about earlier as part of some of your studies?
Yeah, so somewhere along that that string of alphabet from here to the moon, there's a little stretch in there that's if it was from here to the moon, it'd be one little stretch that probably lasted maybe a mile or so, that determines how B cells work, and another little stretch that's a mile or so that determines how T cells work. And yes, we definitely need to stop and look at those areas with extra special attention for stuff like COVID virus infection.
That's such a great explanation. I wonder at a mile, what size font is that? I'm only kidding, of course. To Dr. Puzanov, I'd like to ask if you could help for us to explain how different studies are looking at treatment for COVID and how that differs from trying to solve severe cases versus trying to prevent the patients from developing severe cases to begin with. This is something you mentioned in the discussion of dexamethasone. It has been found in a study to be for very severe patients, improving survival. What are some of the different studies looking at in terms of both of these ends of the spectrum, preventing the onset of the disease from the start versus helping people to survive severe cases, and why are both so important, and help us to tease out what some of those mysteries are a little bit more?
Yeah, this is really important. So, early, you want to prevent the virus to enter your body, period. So, the early study will be actually concentrated on killing the virus with antiviral medicine like a remdesivir, or boosting the innate immune system, like a study we actually developed at Roswell, combination of interferon. Interferon actually is a natural occurring protein our bodies make, and it's called interferon because it interferes with infection by viruses. It was found on that basis. So interferon plus actually a drug called rintatalimab, which is a stimulator of the toll-like receptor, meaning like that first defense on macrophages and neutrophils, the innate or the inherited, kind of a first-line immune system defense. So we hope that, for patients with cancer and early COVID, we can boost their immune system enough so they can actually clear the virus quickly. They never develop any severe COVID, and case closed. That would be wonderful. So this is the study, this is the hope, it's by no means assured, but, this is the idea of early studies. And you can imagine there are 1,000 companies, who are trying to develop a specific antiviral drug, doing these large screens. That's actually part of our global virus network. We talked to a team in Australia, which basically they have this level 4 facility, means like that the most secure, the most, stable facility where you can actually study these deadly viruses like COVID or SARS or Marburg or Ebola. And they pretty much have like a black box, and they put a virus in, and they just throw like thousands and thousands of different components on it, like a screen. And whatever kind of kills it, they kind of take for further investigation, looking for that early hit. So that's early. And then what happens late? Well, two things are happening late. One, there is that cytokine storm. So these are the drugs actually calming the overactive immune system, like possibly the Mk2 Dr. Jensen mentioned, like bruton kinase inhibitors, like anti-IL-6 receptor, tocilizumab or sarilumab, drugs, and Mk2 inhibitors, there. Possibly complement, inhibitors as well. And then, the patients, if they don't actually get better with the cytokine storm, they kind of enter this last phase with a lot of blood clots, a lot of immune collapse. And believe it or not, actually, those T cells express a lot of PD-1, programmed cell death receptor 1. And, the PD-1 inhibitors, which are used in cancer, like Opdivo, Keytruda, the others, the Centric, you name it, they could play a role. We actually had this idea early with Dr. Ascierto in Italy, in Naples. But the problem with these anti-PD-1 drugs is that one of the side effects is pneumonitis, inflammation of lungs. So people are kind of afraid that, are you going to help? Are you going to hurt? So one really good piece of evidence we are looking for is, and where actually cancer patients can help us all, a lot of cancer patients in all cancer centers, including Kansas, including Roswell, including others, are on checkpoint inhibitors. And we really are trying to tease out, if you are having cancer and you have high risk of having severe COVID and dying, we now know that. But what if you have cancer and you are on checkpoint inhibitor? How does that affect, your fate? And if it turns out that if you have cancer, but you are on checkpoint inhibitor, and it turns out that you actually end up better off than average population or average population of cancer patients, that may suggest that actually the checkpoint inhibitors may play some role in either preventing COVID or preventing severe COVID. But we need some evidence because, it is risky, and you have to always, do no harm. Patient safety comes first. And, these data are being collected and analyzed. There was a Lancet paper led by Jeremy Warner from Vanderbilt, my old alma mater, and our Elizabeth Griffith actually was one of the co-authors. And they analyzed over 1,000 patients, and they are teasing out that data. And I'm really, really waiting for it, because if it turns out that checkpoint inhibitors may somehow boost the immune system, then that could be another, kind of a pathway to attack, COVID and help the patients who so desperately need to.
Thank you, Dr. Puzanov. And I want to ask you to elaborate on one aspect of something you mentioned a moment ago. I just want to, one more reminder to our media in attendance. If you have any questions, please do chat them to us and we'll squeeze them in. We have a little bit of time left with our panelists. So please do send those questions in if you have any. And Dr. Puzanov, you mentioned targeting the programmed cell death receptor. One thing that I understand about that from reading recent research myself is that that can sometimes lead to adverse responses from the patient. And that kind of reminds me of talking to one of our panelists recently about developing a vaccine that could also have a boosting effect to the virus if the vaccine isn't effective. How are those kinds of things potentially screened for and tested to determine that these kinds of treatment options are safe and don't add to the effect of that cytokine storm that is leading to death in COVID cases, for example?
So I would start with the checkpoints. So if you think about it, like doing a trial, if you worry about the side effects, and we do, your point is valid, people can develop autoimmune inflammatory side effects from checkpoints. The first thing you would do, actually, you would look at patients in real life, in this case, cancer patients. They already are on checkpoints to fight their cancer. Obviously, they have cancer, you worry about COVID, and you would compare that group to a control group of patients who are not on checkpoints. And you ask yourself a question: is the patient group on checkpoint more or less likely to get COVID? And if they do get COVID, are they more or less likely to get severe COVID with inflammation of lungs, yes or no? And if the answer is yes and yes, well, then checkpoints are probably not the way to go, because if you are on checkpoints and you do worse, you already have you don't need to do experiment. You already have data. If you don't see that, and if you see some protective effect, because with the numbers you can actually see that, then you can say, these patients never get COVID. How come? And they don't get severe COVID, and they don't get these side effects. Maybe it's safe. And then, of course, you have to do the study, and the way to protect the safety, you start with one patient, you follow that patient, then you add two more, and then you kind of slowly add more patients, not in like a big wave. So if you actually have a side effect, you limit that downside, you limit it. The same goes with your other question, anytime we do a study, if you worry about side effects, like in the study we do at Roswell, Dr. Kalinske and Siegel, the combination of the interferon and toll-like receptor agonist rentalimod, we will start with actually one patient, then we will add two more, watch them, then we will add three more at higher level, then three more. And anytime, anybody gets anything, we analyze it, and if it doesn't seem safe, we just, enroll either more patients, go lower, and adjust it. This is what I actually do for a living. This is the phase 1 clinical trials, the early phase clinical trials you mentioned. This is actually my specialty. And that's when you take the drugs from the laboratory, from the research, and you start giving them to patients. It's really important not to harm the patients. Do no harm. Do no harm is our mantra, in this field, and it should be.
Thank you, Dr. Puzanov. So many mysteries to unravel and so much nuance to the way this disease is unfolding, and all of your work is so much appreciated, and your explanations of all this for our panel today. With that, we'll go ahead and draw to a close. I want to just remind folks in the audience that we're going to have a recording and a transcript available. And if you registered, you're going to be on that list to get that information. If you didn't register, send us an email to info@newswise.com and we'll make sure to add you to that. With that, thank you to Dr. Jensen at the University of Kansas Cancer Center. Thank you, Dr. Puzanoff and Dr. Morrison with Roswell Park Comprehensive Cancer Center. Thank you to the communications offices at both cancer centers for helping us to coordinate this panel. And with that, I will say thank you to everybody. Stay safe, stay healthy, and good luck.
Good afternoon. Bye-bye.
Thank you.